So my talk is on classification and management of acute acromioclavicular joint injuries. So these are usually seen in young adults in sports injuries and road traffic accidents. The spectrum is asymptomatic shoulder to painful, significant loss of strength they were usually present with. So classically, Rockwood classification is used where 6 types are there, and but these classification are not clinically decision making point where it's two-dimensional, and the decision based on these classification is disadvantageous. So the type 1 classification is just a sprain of AC ligaments. Type 2, where there is a AC ligament and joint capsules are torn and CC ligaments are sprained and 50% subluxation. And type 3 is including the coracoclavicular ligaments are torn and more than 100% dislocation of the distal clavicle. So ISACOS has, in the consensus meeting, they have divided into stable and unstable type, where the subclassification is based on the functional rather than anatomical classification and based on the cross-body stress views. So type 3B is usually more painful, weakness of rotator cuff testing, decreased flexion and abduction range of movement, and some may demonstrate scapular dyskinesias. Type 4 is posterior dislocation, where the clavicle may buttonhole into the trapezius and trapezius fascia, which can be identified in axillary radiographs. Type 4. Type 5 is exaggeration of type 3 with more than 300% dislocation superiorly, and type 6, which is very rare type, and it is subacromial or subcoracoid dislocation. So we have to be aware of concomitant shoulder injuries, especially the slap tear and rotator cuff tears in more severe AC joint dislocations, which can be identified in MRI based on the degree of AC joint stabilizers, concomitant injuries, and CC ligament injuries. The special X-rays for identifying AC joint dislocations are bilateral Zanka view, axillary striker notch view, and Basamania view or cross-body adduction stress view. So bilateral Zanka view, where the beam is tilted 10 to 15 degrees in a cephalad direction, and it can identify the CC distance and compare to the opposites, and also we can compare the preoperative and postoperative CC distance. Axillary view will help in identifying the type 4 dislocation, where clavicle might be buttonholed into the trapezius, and striker notch view, when the pain is out of proportion, striker notch view will help in identifying the coracoid process. And Basamania view will help in identifying to differentiate type 3 as stable or unstable dislocation. It is based on the amount of the degree of clavicle overlap over the acromion process. So when the patient's pain is out of proportions, we need to suspect a coracoid fracture or type 4 injuries or injuries to the glenohumeral joint. So what do we achieve in management, either by surgical or non-surgical mode of treatment, is achieve pain-free shoulder, full range of movement, normal strength, and no limitations of activities. But the demand on the shoulder will differ from patient to patient. So type 1 and type 2 injuries are always treated conservative management with sling, ice, and immobilization for 3 to 7 days, and then we can initiate movements to reduce associated morbidities. So type 3 injuries are controversial. There is no clear evidence to support. So generally, non-surgical treatment for 3 to 4 weeks, and surgery is indicated for unstable type 3 injuries. And when the patients are treated conservatively and they have persistent pain and inability to return to sports or a job, can be taken up for surgery, and will eventually lead them to return to sports and activity. So the type 3, once initially treated, then we can do clinical examination re-evaluation at 3 to 6 weeks, where pre-existing pain and scapular dyskinesias can be identified, and then the cross-body stress view will show the distal clavicle overlap, and the type 3B can be identified and then taken up for surgery. Or when there is no overrate, then the further surgical management can be continued. And if they fail conservative management, then we can consider surgery in these patients. Where type 3A need no surgery. So on the overall AC joint dislocation with clinical and radiological evaluation, type 1 and 2, there is clear-cut guidelines that can be always treated conservatively, be type 1 and 2, whereas type 3 can be considered based on the stable or unstable as recommended by the ISACO's consensus. Type 4, 5, 6 are generally treated conservative because these are severe type of injuries. So surgical management, there are no gold standard treatment. More than 70 procedure has been described so far. So various procedures like Beaver-Dunn, graft, anatomical reconstruction, arthroscopic fixation are recommended. So by the surgical management, what do we want to achieve? Is anatomical reduction of AC joint where superior and anteroposterior translation are restored. And how do we correct it? In acute injury by a direct repair, and in a chronic injury by a CC ligament reconstruction. The protection of CC ligament can be done with a synthetic material like suture tape or sutures, and a rigid implant like an open reduction and then fixing with the rigid implant, especially in acute conditions, and repair of deltoid and trapezial fascia and distal clavicular excision, especially in a chronic cases. So the open procedures for acute AC joints, where these procedures are used: transarticular pinning, hook plates, CC fixation screws, synthetic loop, circular wire, braided, non-observable large sutures. But these are associated with problems like skin problems, hardware failure, and secondary loss of fixation. So this is an example of 46-year-old man came with RTA where open reduction and then transarticular pinning was done in this case. This is another patient with type 3, more than 100% dislocation, superior dislocation was reduced and fixed with transarticular. This is unstable type of type 3 where the overlap of clavicle over the acromion can be seen, which was again fixed with transarticular fixation. What about hook plate fixation? One of the studies in 2012 showed that hook plate is a good option for acute AC joint dislocation, but they are not without any complications like subacromial bursitis, the tendinitis due to impingement, the acromion osteolysis, and the plate, if plate is retained for long and can be avoided the early removal of plate. So arthroscopic fixation is a good technique where the clavicle is reduced and then the drill is passed from the clavicle into the coracoid, and from the rotator interval, the sutures are shuttled and then fixed with a tightrope or a dog button on superior surface of clavicle and on the inferior surface of the coracoid. So this can be a handy procedure, especially in a young patients where the healing can happen. So this is an example of unstable type 3, which was reduced and fixed with the arthroscopic method. This is another example. So arthroscopic method can be adopted for acute phase with a tightrope to maintain the joint reduction, and which enables a biological healing. So it basically acts like an internal brace, keeps the joint reduced and around which the healing happens, and visualization of achieved reduction, which could explain the low complication rates. So the advantages, the concomitant shoulder injuries also can be addressed, but some of the complications which we can encounter is technically demanding. Incorrect placement of tunnels can lead to the coracoid process, especially in small coracoids and in female patients. The displacement of tightrope can happen, and then the fracture can happen. So coming to the literature review, Jay et al. From his study has shown that single clavicular tunnel is not a good reliable option for CC ligament due to high percentage of displacement and clinical failure. while Gian et al. Has recommended double tunnel technique for anatomical reduction in cases of acute AC suppression with flip buttons, and he had showed satisfactory results at the intermediate follow. So various techniques by the biomechanical studies have concluded that anatomical reconstruction with CC ligament allograft can provide a biologically stronger solution for AC. This can minimize the recurrent subluxation pain and permit early rehabilitation. The other analysis of various mechanical failures due to the AC joint reconstruction showed the 16% mechanical failure, especially when they do reconstruction with the interference screws and the concomitant distal clavicle excision patients. The low failure with the use of additional non-biological fixation can be better, and type 3 injuries were associated with lower failure than with further type 5 injuries. So to conclude, we have to be aware of concomitant shoulder injuries. Non-surgical management is always for type 1 and type 2. Type 3 are controversial, where based on type 3, if it is type 3B where there is an overlap, then we can take it up for surgery. Surgical management or reconstruction for type 3 in which the failed conservative management, and always for type 4, 5 and 6 injuries. So the outcome after surgical reconstruction of CC ligament has been largely satisfactory. Thank you.